And now we move to the next session. We have been a little late. Dr. Pranveet was waiting. So this is a Gopi Devi oration on historical perspective on evolution of treatment of critical limb ischemia, from amputation to bypass to endovascular treatment.
Thank you.
So I'll be inviting a panel. The panel is Dr. Professor Emin Khanna, Dr. Amal Kumar Khan, Dr. Balbir Singh, Dr. BP Singh.
It is for me a singular honor to give the Gopi Devi oration at your meeting this year. And I would like to thank Dr. Khanna most warmly for inviting me. The topic I will be speaking on is the historical perspective on the evolution of treatment for critical limb ischemia, or CLI, from amputation to bypass to endovascular treatments.
First, a word about the past. Some old history. In the 1960s and 70s, surgeons cared for all CLI, and the standard treatment for gangrene and ulceration was a major amputation.
So everything worked. Thank you so much.
In the late 1960s, I and my group began to challenge this standard of amputation for CLI. Although I worked in a poor, disadvantaged inner-city hospital, we had one major asset, and that was excellent arteriography. As shown here in 1971, in this 83-year-old diabetic with gangrene who had only this twig of posterior tibial artery, seen on this good arteriogram, we did a bypass to it and saved this limb for 10 years. We were the first to push limb salvage surgery and a very aggressive approach to limb salvage, employing first bypasses and, when they became available, percutaneous angioplasties. For those of you who don't know me, I am a standard vascular surgeon, but I've always been an endovascular advocate. In 1978, I embraced iliac and SFA angioplasty for limb salvage, and in 1988, tibial angioplasty and later subintimal angioplasty. And we were the first to push redo bypasses, or PTA, when the first procedure failed or was failing. And to do this, we developed a variety of unusual surgical approaches to help. Here are some examples. In 1978, the 78-year-old diabetic lady was told that she needed a major amputation at 3 other major New York City hospitals because all her veins had been stripped. Our angiogram showed only this isolated segment of posterior tibial artery, mostly below the ankle, and no other usable target arteries above this level. We did a PTFE bypass to that posterior tibial artery segment, took off another toe and debrided the foot. 2 weeks later, it looked like this. We put on a skin graft, which healed nicely. We knew that few would believe that such a PTFE bypass would work long term, so we did this arteriogram 4 years after the procedure, showing that it clearly was working and enabling this lady to walk for the 6 years that she lived after the initial procedure. We were also the first to show that extensive foot and even heel gangrene were not a contraindication to limb salvage. Here is extensive ischemic heel gangrene after an anterior tibial bypass and heel debridement. The heel looked like this, with necrotic os calcis exposed. After removing the Achilles tendon and ronduring off the necrotic os calcis, we got a wound that looked like this. With a skin graft, this elderly gentleman was enabled to walk for the 6 additional years that he survived. We were also the first to do vein bypasses to very distal pedal artery branches. Here shown are the medial and lateral plantar branches of the posterior tibial artery. Both can be used as targets for distal bypasses. Here is one such bypass after 4 years. Shown here are the deep metatarsal arch and lateral tarsal branches of the dorsalis pedis artery. Both of these branches can be used as targets for distal bypasses. Here is one such bypass to the lateral tarsal artery, patent for more than 12 years. This patient represents the limits of limb salvage. Another surgeon had attempted unsuccessfully to do a bypass to the posterior tibial above the malleolus, and this man came with extensive gangrene. He was very sick with multiple strokes and MIs. I told him that he needed an amputation, major amputation below the knee. However, he had a very attractive daughter who persuaded us to at least do an arteriogram, and we did, showing good circulation down to the mid-leg, and then only this twig of posterior tibial below the malleolus as being patent. We did a vein bypass to that twig of posterior tibial. It remained patent. We removed the necrotic portion of the foot, and 8.5 years later, this patient was walking at home, despite the fact that he only had a remnant of his foot left. Now, one might say that it was not worth saving so little a portion of his foot. However, it allowed him to be taken care of at home despite all his comorbidities and a bypass on the other side, and he lived a fairly comfortable life for the 8.5 years that he survived. And towards the end of his life, we did an arteriogram because of trouble on the other side, and you can see this very atrophic vein graft to this very limited outflow tract was still patent and enabled him to stay at home and be taken care of by his family for the 8.5 to 9 years that he lived. These are only anecdotal cases that I've shown, and one could fairly ask, is all this worthwhile for the population at large with threatened limbs? We believe the answer is a resounding yes. We believe this because in 1981, we analyzed the outcomes in 551 limb salvage patients subjected to the procedures that I have described. Interestingly, after 5 years, half the patients had died from other causes, mostly myocardial infarctions. Of the other 50% of the patients who survived for 5 years, 2/3 of them kept their limb on and functional for the 5 years that they survived. And of those who died before 5 years, anywhere between 81% and 95% kept their limb on and functional until they passed away from other causes. In another analysis of over 3,500 patients that we published in 1990, over a 16-year period, when we analyzed these patients, our amputation rate fell from 49% at the beginning to 14% at the end of the period of analysis. Moreover, of patients with a threatened limb, large group of them that we experienced, more than 98% of them had a pattern of disease which was suitable for revascularization either by an open procedure or by some form of endovascular treatment. So we concluded that except for a rare patient like this with extensive gangrene, who clearly needs a major amputation, we concluded that in most patients with limbs threatened by arteriosclerosis, the aggressive use of all these and other limb salvage techniques, including reoperations and repeat angioplasties, were worthwhile when employed in a large series of consecutive patients. At first, others, including other surgeons and vascular surgeons, doubted us and thought our aggressive approach to limb salvage was crazy. As you all know, this approach is now generally accepted by all vascular specialists. As you all also know, the present is a changing world. In the last 15 to 18 years, there's been a sea change in the treatment of infrainguinal arteriosclerosis. Up to 15 years ago, the treatment of infrainguinal arteriosclerosis was primarily open surgery supplemented by catheter-based treatments. Now the treatments are primarily endovascular. That is, endovascular is the first option with a variety of techniques that will be described at your meeting. Indeed, there are now some who say there is no role for open bypass surgery. If you can't treat the patient endovascularly, treat with an amputation. Is this right? I believe it could not be more wrong. There's still a substantial number of patients with infrainguinal arteriosclerosis who need an open surgical procedure, be it bypass or thrombectomy, at some time in the time course of their disease. What that proportion is, I do not know. It's probably around 20 to 25%. What about the future? There are already glimmers in the present, and you will hear about most of them at this meeting. As technology improves, more than 85% of procedures for CLI will be catheter-based. Although many procedures will be very distal and very difficult, and redo procedures will often be required. Endovascular options will include many new technologies, which you will hear about at this meeting. However, the efficacy of these new procedures must be proven by good trials, and cost will always be an issue. So my conclusions, the positive. Interventional treatment of lower extremity arteriosclerosis is the hottest new area in vascular disease treatment. Statin treatment will keep patients alive, but won't help much here otherwise. There's a great need in this area, many patients. Many advances will be made over the next decade. The negatives. There are many variables in this area, which makes it hard to prove treatment value. There is a need for high-level evidence and a high level of endovascular skills. There will always be a need for open treatment. Cost is a big issue, and one must be sure that there really is a need to employ these treatments.
Thank you so much for the honor of having me give this prestigious oration.
Thank you very much, Dr. Frank Wieth, for giving this wonderful lecture. And this is the Gopi Devi Oration Award, an oration. So let me just read out the citation to you. Because of the lockdown, we are not able to give it to you or send it to you by courier right now. But the moment things ease out in India and the flights are on, we would be giving it to you. It reads as APFIC 12 Online Asia Pacific Vascular Society. Asia Pacific Vascular Society Gopi Devi Oration for the year 2020 has been conferred on Dr. Professor Frank Wieth, Chairman Wieth Symposium, United States of America, for the topic Historical Perspective on Evolution of Treatment of Critical Limb Ischemia, Mutation to Bypass to Endovascular Treatments. On the Asia Pacific Vascular Interventional course held virtually at New Delhi from 26th to 30th June 2020 for his distinguished contribution into the field of vascular medicine. The Pacific Vascular Society wishes him many more years of good health and academic excellence. Dated this 27th June 2020. So this is the citation for the Gopi Devi Oration Award to Dr. Frank Wieth. It would be wonderful if Dr. Wieth he's actually online, but Yeah, but
yes, Professor Khanna, I'm here, and I greatly appreciate this award and this honor. I hope your meeting is a great success. I don't know if you can see me or not.
I actually can't see you, but I can hear you very well.
Well, if I tried to start my video and for some reason it's not coming on, but anyhow, I've heard a good bit of your meeting. I think it's excellent. Some of the preceding cases were very exciting and also challenging. That's the nature of treating vascular disease. It's not an easy business.
We are so excited and honored that you could join us like previous years, and you are one of the role models for our vascular specialists across the world. They have all grown up to be like you and to actually emulate a lot of qualities in you. And the Asia Pacific Vascular Society and VEITH Symposium have long-term collaborations, and we actually wish that we work together with VEITH Symposium in future too.
Yeah, no, we feel exactly the same, Professor Khanna. What's interesting to me is some of the things that I've seen today are truly amazing. I mean, as an old timer in this business, what can be done today is just it's unbelievable and good. And I think that we're just at the beginning of a new era. If health returns with this COVID virus conquered, I think we'll see many new and better techniques, and the treatment of vascular disease and cardiovascular disease will be one of the most exciting areas of progress in medicine. So good luck to all your attendees, and enjoy the meeting. And
Thank you very much. We are
there.
expecting about 5,000 delegates even today. And yesterday we had Greg Stone, Alan Lumsden, we had Roger Grinnell, and also, Horst Siewert. And today we had you, and we have Dr. Farid Murad, who's a Nobel laureate in medicine and the discoverer of nitric oxide. So we have exciting faculty and a lot of national and international delegates spread from all over the world. I think this
very exciting business. Very exciting business.
Thank you so much, and we are honored. Thank you, sir.
Well, I'm honored too, and thank you.
Thanks. So let's move on to the next presenter, who would be Dr. Sriram Narayan, who would be Dr. Arnd Schoen. He's going to be speaking on shockwave lithoplasty in vascular applications of shockwave lithoplasty, and we have heard him earlier, and we had a joint webinar maybe a month earlier. So Dr. Schoen, over to you.